So Professor Veer Bahadur Singh, who's a senior professor and head of Department of Medicine at SP Medical College, Bikaner, would now be addressing these two issues. Dr. Veer Bahadur Singh, please.
Good evening, sir. Am I audible?
Yes, sir. You are audible, sir.
Yes, sir. First of all, sir, sorry because of the delay. I was stuck up in the traffic in the Patna. I was in at airport, and then the flight was late. That's why it was some problem. Thank you very much, Professor Vinod Kumar, sir, who has given me this opportunity to be in front of you. As you know, we are discussing today is influenza and the pneumococcal vaccination for adult and elderly. Uh, why there is a need of this adult vaccination? Because the rapidly growing elderly population in India, this is the main reason. Then in India, the aging associated with the immunosenescence, then increased susceptibility of the infections. This is again a reason why we are looking for the adult vaccination. Then the chronic non-communicable diseases like risk of severe pneumonia and hospitalization and death. The vaccination uh, of either adult vaccination or non-adult vaccination. The vaccination is cost-effective and preventive strategy. And definitely, this type of the vaccination reduces the antibiotic misuse and the antimicrobial resistance. Uh, a few words about the immunosenescence. It decline in the native T cell population and it reduces the T cell antibody affinity and it impairs the response to the infection and the vaccines. And the conjugate vaccines overcome age-related immunodecline and definitely the annual vaccination help the countervailing immunity. That's why this is required. Then, in this slide, I will try to explain what is the burden of the influenza in the India. You can see by this graph in India, the influenza is a major cause of the acute respiratory illness in India. The disease burden is underestimated because of the underdiagnosis of the diseases, especially the respiratory diseases. Limited routine testing is available in few urban as well as in the mostly in the rural areas, and overlap with the other viral respiratory infections. These all are the uh, reason for the uh, disease burden in the underestimated. We can see in this the major part in the last slide. We can see yes. This is the major part of this disease is the influenza virus, which is mostly not only in the adult but it is also in the elderly also. Yes. Then a few words about the epidemiology of the influenza in the India. As you know, the influenza virus circulates throughout the year. The seasonal peak is vary by the geography. The monsoon regions most available in the most of the regions. The winter months, November to February in northern India. The south, both influenza A and B contribute to the disease burden. The influenza A subtype H1N1 and H3N2. You can see in the northern part of the India, the December and April. In the central part of the India, you can like Lucknow, July, September. In northeast, there is mainly the June and August, and in the south we can see in like Chennai and Vellore, the October to December, the influenza epidemiology is there. As you know, the influenza accounts for a significant proportion of the influenza-like illness. The severe acute respiratory infection, SARI cases, it contributes the substantially to out patient visits, hospital admissions, and definitely ICU utilization during the peak seasons. And there is a burden on the society as well as in the hospitals. It also affects the persons over the age of the 60 or above, the chronic lung disease, COPD, asthma, and bronchiectasis, chronic heart disease patients, mostly diabetic patients, chronic kidney disease patients, chronic liver disease patient, morbid obesity, pregnancy, and definitely we are the culprit. Healthcare workers is also suffered by these type of the infections. Then types of the influenza vaccine available in the India: inactivated influenza vaccine, egg-based or the cell-based influenza vaccine, trivalent and the quadrivalent formulations. The quadrivalent vaccine preferred because of its higher immunity, and the live attenuated vaccines not recommended, especially in the elderly persons. Then, what are the indications of influenza vaccines? All adults aged 18 years and above should be given the influenza vaccine yearly. Elderly aged 60 to 65 years and above is mandatory. The patients with the chronic cardiorespiratory diseases also needed this vaccine. And the influenza vaccine definitely and absolutely indicated in the healthcare workers and caregivers. And it definitely we can give the influenza vaccine in pregnancy in any trimester, maybe first trimester, second trimester, or third trimester. Then influenza schedule: the single dose sufficient for the adults. It administers annually before the influenza season, and it covers it has the good coverage. There is no booster required within the same season. This is a plus point of this vaccine. The late vaccination still provides the benefits, but not so. The yearly revaccination is mandatory. So these are the schedule of the vaccination. Then type of the vaccination: standard IIV, high dose IIV, urgent weight IIV, and recommended vaccine, recombinant vaccines. Standard IIV is the age group we should given the 18 to 64 years. The dose is zero point 0.5 ml. It's intramuscularly, and high dose IIV more than 65 years. The dose is zero point 0.7 ml, and it's again given intramuscularly. The adjuvanted IIV is more than 65 years, but the dose is less, is zero point 0.5 ml. Definitely, it's again by the intramuscular. And the recombinant vaccine, it should be given more than 80 years. The dose is the same. And the plus point of this is it should be given yearly. Then we can give the vaccine in pregnant women also. All women who are pregnant or who might be pregnant during the influenza season should receive the influenza vaccine. Influenza vaccine can be administered at any time during pregnancy. There is no contraindication. Then these are again the dose schedule which I have already described. You can see the next. Yeah. Then there is some contraindications, safety and contraindications. The local pain and mild fever, as you know, it's always with most of the vaccines. Then severe allergic reaction is very rare with this influenza. The egg allergy, not absolute contraindication. The live vaccine contraindicated in the immunocompromised, and GBS is extremely rare by these vaccines, which is very common with other vaccines. Uh, this vaccination reduces the hospitalization rate by 40 to 60%. This vaccine decreases the ICU admissions and the mortality rate. Uh, Influenza vaccine effective varies within the strain matching. Influenza vaccine, high dose vaccine show better immunogenicity, and it provides the herd immunity benefits to the patients. Influenza infection induces the systemic inflammation, endothelial dysfunction, and the prothrombotic states. Acute influenza can participate plaque rupture leading to the myocardial infarction. Influenza vaccine significantly reduces the major adverse cardiovascular events. It protect it protect the cardiovascular effect observed within the week of the of vaccination, and it is strongly recommended in the patients with the established coronary artery disease. Then now the second vaccine is pneumococcal. So what is the burden of pneumococcal disease? It's caused by the Streptococcus pneumoniae, major cause of the community-acquired pneumonia, adult as well as in elderly, where the mortality rate is very high. It causes meningitis, sepsis, and the bacteremia. It again leads to multiple admissions and high morbidity as well as the mortality. The high mortality in the elderly population is the main cause is the pneumococcal infection, and the prevent it is always preventable by effective vaccination if it should be given regularly and in time. Uh, the pneumococcal vaccines, the PCV13 conjugate vaccine, PPSV23 polysaccharide vaccine, newer PCV15 and PCV20 vaccines are also available. The conjugate vaccines induce the immune memory, and the polysaccharides vaccines covers more serotypes. Then there is a few difference between the pneumococcal conjugate vaccines and pneumococcal polysaccharide vaccines. Uh, it protects the protection by the pneumococcal conjugate vaccine is a longer protection in comparison to the pneumococcal polysaccharide vaccine, where the protection is very short. It stimulates the T cell immunity. It induces the mucosal immunity, and effect on the nasopharyngeal carriages is there, but it's not with the pneumococcal polysaccharide vaccination. Sir, some indications of the pneumococcal vaccinations. All adults age 65 years and above, adults with the diabetes mellitus, chronic heart disease, chronic liver disease, chronic kidney disease patients, and asplenia or the immunocompromised states, all are indications for the pneumococcal vaccine. We have few options. PCV20 is a single dose we can give. Then the pneumococcal vaccine timing for adult 65 years or the elderly, the administration of single dose of the PCV at least 1 year after the dose of the PPSV23 for all adults, regardless of the medical conditions. Then pneumococcal vaccine timing for the adult of 65 years or older. Administer one dose of the PCV13. Administer one dose of the PPSV23 at least 1 year later for the most immunocompetent adults, or at least 8 weeks later for the adults with the immunocompromised conditions. Then pneumococcal vaccine timing for adult with the certain medical conditions like CSF leak, cochlear implant, sickle cell, hemoglobinopathies, and HIV infections. The PCV13 for at least should be given in between the 19 to 64 of years. In chronic renal failure, uh, just a minute. And PPSP23 in 19 to 64 years, it includes the chronic heart and the lung disease, diabetic mellitus, alcoholism, and chronic liver disease patients. Why should be PCV13 is given before 23 ppb? This is a question. Why both PCV13 and 23 ppb recommended for those with a high risk group people? Because the immunization with the pneumococcal polysaccharide vaccine can decrease an individual's immune response to subsequent pneumococcal immunization, and that's why it should be given before. The giving the prevener 13 uh, uh, giving the prevener 13 8 weeks before the pneumovax 23 allows the individual to maximize their response to the pneumococcal conjugate vaccine. The immune response to prevener 13 is better and expected to the last longer. And the administration of the pneumovax 23 8 weeks after the prevener 13 is recommended to broaden the protection against an additional 11 pneumococcal serotypes. That's why it should be given. And then vaccine PCV13, PCV15, and PCV20 intramuscular but there is no need of the booster dose. But PPSP23, the dose is the same, but there is a booster dose is required. It is a high risk. BPSP booster after 5 years in a high risk patients indicated in the asplenia and the immunocompromised. No revaccination needed for the PCV. Avoid excessive polysaccharide dosing, and the follow the guideline of based on intervals. Then co-administration of the vaccines. Influenza and the pneumococcal vaccines can be co-administered without any harm. Use different injection sites. No reduction in the immunogenicity. It improves the vaccination coverage, and it is a recommended practice, especially in the elderly population more than 60 and more than 65 years of the age. Influenza vaccine must be given annually. Pneumococcal vaccine recommended after 65 of years. PCV should always be preceded by PPSV 23. High dose influenza vaccine prepared in the elderly. Co-administration of the vaccine is safe. So, the both vaccines, influenza vaccine as well as the pneumococcal vaccine, are mandatory in especially in the elderly population and in the adult population also.
I think that
Uh,
thank you
Thank you,
very
sir.
much, sir. And